Let's kick off by hearing a bit about you, Michael, and your own background within the SNF space.
A pleasure to be here with you today. I've really enjoyed co-creating this with you. And I'm excited to talk about an industry where there's still a lot of confusion and misunderstanding, but also opportunity. I really believe that skilled nursing has an opportunity to really evolve in care delivery and care quality and operational rigor and clinical delivery. So there are lots of great ways that the industry is going through a series of changes right now. So it's an exciting time in skilled nursing in an industry that has been largely relatively unchanged for many years in a lot of ways, but I'm starting to see opportunities to move forward. So I started working for a long-term care organization, or one that also does long-term care, the Masons of California, about a decade ago, a little over a decade ago. First as CIO for them, and then Chief Operating Officer for the Masons of California, one of the entities or several of the entities of which run long-term care, including both assisted living as well as skilled nursing in California. And I will say the learning curve is very steep, as some of the folks watching this can probably appreciate. Skilled nursing is very unlike assisted living and very unlike other parts of healthcare in that it's much more complex. So there's more to it. So I feel like even after a decade, first with the Masons and then with an organization called the Jewish Senior Living Group, which managed a couple of different communities around California, both assisted living, and we ran the largest private nonprofit skilled nursing facility in the state of California called the San Francisco Campus for Jewish Living, which was about 400 beds of skilled nursing and about 100 of that post-acute and the rest of that long-term care. So really got a chance to see upfront and firsthand the delivery of care in large, complex skilled nursing, dive into some of the compliance and regulatory aspects of that, look at some of the operational elements. First as CIO, so I understood the technology and was a buyer of the technology for skilled nursing. And then as COO for the Jewish Senior Living Group, and really understanding some of the operational workflows, clinical delivery, care and quality metrics, some of our work with the hospital partners around the San Francisco Bay Area, and other aspects to running a large, complicated SNF.
And your current role?
My current role, I am now back on the other side of the table, as it were. I am now serving as the Vice President of Healthcare Technology for North America for Viar Imaging, based in Israel. And now I find myself back in the role of selling back into SNFs. So this is a topic that is very present and important to my day-to-day life as well.
I think it's a rare combination to really be able to zoom out and understand the macro industry trends and where things are going, but also to really be able to deep dive into intricate tactical details, and that's why I think this is great to work on with you.
Yeah, no, it's a fascinating industry, and again, I really believe it is going through an interesting inflection point. Skilled nursing was really at the center of the storm in COVID, so it has precipitated some rapid changes, and there are more changes that are coming down the pipeline. Regulatory changes, operational changes, quality and staffing mandates, and other things that may or may not transpire. So it's a period of intensive change in skilled nursing. And going through COVID, we had regulations and requirements that would change weekly. Sometimes you get something called an all facilities letter, an AFL, that basically can redefine how you operate. So one week you're letting visitors in, and the next week you can no longer let visitors in by law. It's basically public health saying this is no longer safe and changing how you operate. So it is a very dynamic, for a very structured industry. It can also be very dynamic, as we saw in COVID, and it has precipitated some rapid evolution and opened the doors, I will say as well, to looking at things that have been done the same way or very similar ways for many years, and opened up new opportunities for operating and improving how care is delivered.
And like many segments or stakeholders in healthcare, the more you learn about it, the more you realize it's a real rabbit hole of its own vendors and incentives and details. And so let's, dive in.
Yeah.
And ideally, those listening will have the checklist next to them as you watch this and it's meant to accompany this video. And if not, go to lionbird.com/SNF-cheat sheet to download it. And so we're all, of course, aware of what a nursing home is and of the concept of long-term care. You touched upon it in your bio, but I think one of the interesting things that a lot of people are confused about is that this is an umbrella term. There's multiple care settings within that, each with their own drivers, incentives, regulations, economics, it can get pretty confusing. And so I think just to start out, to create a baseline, can we maybe clarify in simple terms, what are some of the care settings that you might find in a long-term care group, such as junior senior living group, or the customers that you currently have, and which parts are we focusing on in this video and in the cheat sheet? What are we referring to when we say SNFs?
Skilled nursing facilities. First, it's the acronym. So people, when you talk about a SNF, people look at you like, what are you talking about? So SNF, skilled nursing facility, is a generalized term that generally is used to describe not just long-term care, sort of what you think of when you think of the traditional nursing home or other nursing home level facility. So there are other types and styles of facilities that also provide nursing home care, but it's, in addition to the long-term care, it is also post-acute care, is licensed under a skilled nursing license. So after you have a knee replacement or a hip replacement, for example, in acute care, generally speaking, there are a few exceptions to this now, you don't go straight home after a new knee. You would go to a post-acute center, which may or may not be a standalone post-acute center or within a skilled nursing facility that probably offers both long-term care and post-acute services. You'd stay, generally speaking, for 2 to 3 weeks, and then you'd go home after that, rehabbed to the point where you're back up to a functional level of a functional condition where you can get along by yourself at home. So usually it includes not just, most people think of skilled nursing, they think of long-term care. It's important to remember that skilled nursing can also include post-acute care and even subacute care, which is sort of a step higher in terms of acuity and in terms of the types of conditions. With subacute, we won't talk about it too much today, but again, it's important to understand that when you talk about skilled nursing, it's an umbrella term that includes a few different types of care. And in terms of acuity, I would say acuity levels are rising in skilled nursing, generally speaking. That basically means how sick you are, how compromised you are from a healthcare standpoint. Generally speaking, it's a step down from what you would see in acute care. And it's a step above what you would see in, say, an assisted living facility or an RCFE, a residential care facility for the elderly.
Thanks for that. And the cheat sheet, I think we started with an opening few paragraphs that kind of go further into detail on that, since it's just such an important topic. And so further segmenting, I mean, you did a great job describing long-term care. There's also, of course, the larger domain of senior living, which includes other settings, and it also gets lumped in, all together as one. But maybe you can give the audience a quick overview of some of the differences between some of these settings and why it's important to distinguish between them.
That's a very critical thing to understand once you're interested in selling into senior living. Some folks think that it's all the same or it's similar enough that it's not that big a deal. It's really important to separate out skilled nursing and all of the pieces that fall into skilled nursing from really the rest of senior living, which is residential services. So it's usually referred to as assisted living or independent living is again, even lower level of acuity and lower needs there. But understanding that senior living is a catch-all phrase that includes both healthcare style services or healthcare services in skilled nursing, as well as non-healthcare services, generally speaking, that are much more around support for generalized activities of daily living in assisted living, certain types of memory care, because memory care is also a term that can be both used in skilled nursing. You can have skilled nursing memory care, and you can also have assisted living level memory care. So take the time to dive into which part of the senior living continuum you're interested in and you are appropriate for with your solution. Understanding that the regulations, the requirements, the operating models, the staffing levels, they're very, very different between skilled nursing and assisted living. So take the time to understand the difference there before you move forward with one or the other, because they're significant.
We really focused just on SNFs. I think that's enough more than enough to fill, an entire book, and we'll save assisted living for another video.
It's actually where most of the complexity is. If you have to look at the whole continuum, most of the complexity resides in skilled nursing. So yes.
Getting into that checklist, as I mentioned earlier, what we tried to do with the first section of questions was to consolidate in a very concise manner the top 10 high-level value propositions that you might want to highlight as a vendor trying to sell to SNFs. And the idea is to use that to help guide messaging and ensure you're hitting on the points that buyers care about. And are there any within that list that you might highlight as particularly standing out above the rest as a top priority today that must be included in vendor pitches in today's market?
I'd say a couple of things are really important when you're pitching a SNF. One is before you go in there, understanding, at least at a basic level, how they operate and what matters to them. So what I mean by that, how they operate, really looking at first understanding which part of or which type of skilled nursing you're selling into, whether it's post-acute or long-term care. That determines a few things, or that changes a few things in terms of staffing ratios, in terms of how care is delivered. It really helps you understand the context that they operate within and some of the other financial or reimbursement drivers behind that as well. So understand where you're going with that and who you're selling into. Understand as well that you may be selling into a couple of different sort of user personas, if you will, depending on a couple of factors. One, whether it's a standalone, what we call a standalone SNF, a standalone skilled nursing facility that operates by itself, if it's part of a larger management group. So you may be talking to a corporate person, a corporate operator that operates a couple of SNFs or some number of skilled nursing facilities or other facilities, or more of an enterprise level where they're operating, hundreds or thousands of facilities in some cases. So it's important to understand what their context is as well. Are they focused on really the day-to-day operations of that skilled nursing facility? Are you talking to the licensed skilled nursing facility administrator, the LNHA? Every skilled nursing facility has at least one, by requirement, licensed nursing home administrator. There's another acronym for you, LNHA. You have to go out and get a license to run a skilled nursing facility. And their license, as we say, is up on the wall. So it is their responsibility to make sure that care is delivered appropriately. And they are legally on the hook as well if something goes very wrong, because that drives their ability to operate and stay open and in business. Their census, for example, they know if you ask them at any given time, they will be able to tell you off the top of their heads, most likely, what their census is. And by that, I mean how many beds are filled. So if they have, say, 100 beds, most skilled nursing facilities are a little smaller than the one I was with. They're anywhere from, say, 30 beds to 120 beds, maybe at the high side for most on average. So they know out of, say, 100 beds that 92 are filled on any given day. So they pay very close attention to that because that's how much reimbursement they're also getting, or that determines that. So understand what their metrics are, also understand what time of the year it is. And by that, I mean, periodically, each skilled nursing facility is supposed to go through about every 18 months, give or take. And the variation has been more significant during COVID. But there's a survey process that happens with skilled nursing facilities that if survey is going on, people won't even respond probably, because they have to be laser focused on working with effectively the auditors that show up unannounced, evaluate the level of clinical care, how things are going, and then basically give them a list of deficiencies potentially if they find things that are in error. So understand not just the overall context, but the timing of your engagement with them, because you may find that all of a sudden you are having a great sales pitch with them or conversation, and then 2 days later they disappear. So try to understand the context that they're operating in.
One of the, if we were to kind of skip ahead in the question list and go to the section 3 about understanding how money flows and how to best position your offering for available budgets. One of the interesting points that you brought up for the question list is, are your users at the SNF or are you selling to a corporate or a management entity? And so I think it's interesting if you could elaborate on why the legal structure of a SNF operator is important for a vendor to understand, and how this may impact the go-to-market or product strategy, whether it's top down or done at, if decisions are done at the local level, for example.
Yeah, it really will shape who you talk to, how you're pitching it, and what matters to them. Because, for example, the on-site administrator cares about a different set of things on a day-to-day basis than, say, a regional operator who's sort of paying attention to a portfolio of skilled nursing facilities that they're managing. And there are other considerations that I haven't mentioned yet, but that are in the cheat sheet, like their star rating, which is made up of a few different factors. So it's important to understand who is operating the facility or facilities, what they are focused on. And again, even at a regional or enterprise level, they will still be focused on things like census, because at the end of the day, it's how many beds you have filled really determines your operating capacity and your financials. But looking at how they make decisions. So, for example, an individual SNF operator may not be able to make a decision even for their own building if they report into a larger regional structure. They may be able to make day-to-day decisions about care delivery and other things, but to pick a new solution for anything from technology to dining to care delivery or other things, they may have to check in with their regional operator to get approval to make some changes in how they're going to deliver the care or any other aspect of what they do. So really understand that you're selling into the right person. Otherwise, you're talking to someone who won't be able to make a decision or won't be able to sign off on that. Although sometimes it's necessary but not sufficient, as we say. So you may actually have to get buy-in from the local level before you go to the regional level. So understand the hierarchy of the given organization that you're working with or pitching into, because there may be various levels of approval. Different people may want to see different things. For example, right now, labor is a big deal in skilled nursing facilities. There isn't enough of it out there. So everybody needs more nurses, more CNAs, more LVNs or LPNs. So a solution, let's just say you have a shift management platform, a nursing shift management platform that helps you optimize how you're staffing all of your shifts across the skilled nursing facility. You may have a couple of people who have to buy into that. It might be the director of nursing. It might be the administrator. And by the administrator, it's the licensed nursing home administrator. It might be a regional COO. It might be a few different people. It might be a head of HR. So understand who if there's a population or a group of people that need to make a decision about this, figure out what the entry point is, because the entry point may be different than sort of the decision by committee, unfortunately, that happens sometimes, or who the final decision maker is in that process, so that you make sure that you get buy-in there. I will also say that especially right now, especially with all of the labor challenges and the upcoming mandates and what COVID has done to many of these organizations, margins are exceptionally thin in this industry. So you really have to go in understanding and being able to articulate exactly how you're going to deliver value there. Because if you can't do that, most of these folks are so busy and so pressed for time and resources, it's not even going to register as a priority.
Yeah, and so one of the things that we mentioned in the cheat sheet, and it's very aligned with my experience as investor, is that it's critical right now to show you can help providers ideally even drive increased revenue in the very short term in a measurable, attributable way. And one way to do so here, which you alluded to earlier, seems to be via impacting a SNF's average daily rate, which is related to the amount you're reimbursed each day. And this has been a moving target. It's very complex just because of the fact that Medicare is the primary payer and it's moved towards the PDPM model. And so would be great, I think, if you could provide some basic background on how average daily rate is determined within this framework and what vendors can do to potentially tie their value prop into maximizing or enhancing this metric.
So are you selling to that licensed nursing home administrator, which may or may not be the CEO or the COO or the person running the day-to-day operations of that skilled nursing facility, but they are responsible for the care overall? You might be talking to a director of nursing that is responsible directly for the clinical care. You might be talking to a CIO or a COO, depending on if it's a technology or an operational solution. So really understand the type of person you're talking to, their context, whether it's a single site or multiple sites, and really understand what they care about the most. So part of what these operators focus on are a couple of key metrics. Some solutions may have no capacity to drive the revenue side. They can only drive cost reduction or efficiency. So just understand specifically the bottom line. If you leave with nothing else, understand where you drive value. Is it cost or is it revenue? On the revenue side, a couple of years ago, the reimbursement model shifted from something that had been around for a number of years to PDPM. So from resource utilization groups, or RUGs, as they were referred to, which basically, and this we're talking about post-acute here, basically looked at how you are delivering care and the number of minutes and other things to a much more complex model in PDPM, looking at a number of different aspects, including clinical complexity, how care was delivered, what this person's needs were. So it's a much more complex set of criteria, which frankly are largely determined not by the vendor, but by on the admission side, when a patient is going to be admitted, looking at the sort of the clinical profile of that person, that really determines the revenue basis for that engagement with that person, that patient. So there's not a whole lot you can do there other than looking at making sure that those clinical services are captured and accurately represented. Again, most of that is done in the electronic medical records system, but it's also making sure that the staff know how to document that, because as we say in skilled nursing, if it wasn't documented, it didn't happen. Really, with reimbursement, again, that is absolutely true. So you have to make sure that everything is very well documented. So there are opportunities in staff education and training to make sure that things are accurately and well documented. There are a couple of layers of checks and balances on that, usually with most skilled nursing organizations, to verify that what they thought was delivered was actually delivered. But I will say revenue is very difficult to influence in most cases, unless you're either working on optimizing how the staff are recording this information, optimizing the flow of patients into a skilled nursing facility, or otherwise looking at how care is delivered. It's generally speaking, much of the sort of value prop is going to be cost savings on these engagements and pitches. Again,
And beyond,
it depends on the level of care, though.
no, that's great. And beyond average daily rate is length of stay as
Yes.
another critical KPI. And so maybe you can give some insights on how length of stay incentives are maybe structured and what vendors should know about that.
Absolutely. So there are both guidelines and requirements around length of stay. So length of stay is how long someone stays in a skilled nursing facility. And that is generally speaking tied to reimbursement. So depending on the level of care within a skilled nursing facility, so their level of or length of stay is focused on much more, obviously, on the post-acute side, because you only get so many days of post-acute care according to the government in a given year versus in a long-term care environment, which is a little more open-ended depending on a few things. But length of stay is absolutely something that many of the partners that skilled nursing facilities work with, for example, the hospitals or the payers, are paying very close attention to, because, for example, they know how long someone coming in with a new knee should stay in a skilled nursing facility. And if that patient ends up staying longer and significantly longer, they will apply a lot of pressure, because they're paying a daily rate for that person to be in the skilled nursing facility. And there's a lot of pressure to get that person basically discharged back out and sent back home. So both the skilled nursing facility and their partners are paying very, very close attention to average length of stay and length of stay for a specific patient as well. And what influences length of stay is really how quickly someone is recovering and proceeding through sort of their clinical path. So there, it's looking at how care is delivered, how if you can improve care or find other issues or prevent issues that come up and that might keep someone there. For example, pressure sores are something that either someone may come in with, or unfortunately, sometimes something that develops when someone is staying in a skilled nursing facility and isn't getting up out of bed. You can develop sores on your skin that can become very, very serious and actually extend the necessary stay in some cases, just as one simple example. So paying attention to the clinical criteria of the person, making sure that they are both well cared for and then are discharged in a timely fashion when you're talking about post-acute, are things that people are very much paying attention to, and also are reflected in the STAR rating ultimately as well, in the quality management scores. So length of stay is one of the key metrics that people pay attention to for a number of different reasons. But what makes up that length of stay, again, depends on a patient by patient basis. But understanding that is absolutely a metric that skilled nursing operators are very cognizant of, and also have to defend in some cases if someone is staying longer than someone else thinks they should.
And since you mentioned it, twice now, the CMS survey performance and and stars. Maybe you can elaborate based on your experience exactly how important these surveys and ratings are to SNF buyers and how they actually tie into their bottom line performance, because it's not really the same across all stakeholders. And some they have less penalties and incentives than others. So how do they kind of work in the SNF world?
Absolutely. An organization is going to be very, very aware of their star ratings for a few reasons. One, it does tie into their capacity in many cases, depending on the star rating, to even get reimbursed or be reimbursed or stay open. For example, if your star rating slips too low, you will be shut down or potentially, or if you have a deficiency that ties into your star rating, you could be shut down. So it's very important to understand there are a few things that tie into that star rating. We'll talk about that in a second, but providers are very, very focused on maintaining or improving their star rating in the ways that they can, whether it's the quality measures, which is usually where you have the most control, and staffing. So let's talk about what makes up a star rating. I think that's the best place to start, maybe. There are essentially three things that make up a star rating. You have your staffing, you have your survey performance, as we talked about a bit, and then you have your quality measures. So the three of those, and if there's an algorithm behind that, they're not equally weighted. You have to maintain a certain level of staffing. And as I mentioned earlier, there are mandates coming down that are going to probably change those ratios to some degree. But you have to maintain a certain level of staffing to provide the care that you are providing. The government essentially knows that, and there's been good research done behind this, that the more staff you have, generally speaking, the better care you deliver. There's a strong correlation there. So that's one, staffing. And again, as I said, with the staffing crisis right now, or the staffing issue in healthcare and specifically in skilled nursing, that is one of their greatest areas of challenge because the costs associated with staffing are increasing and they're having a hard time or harder time finding and retaining great staff. So staffing, when I mean staffing, we're talking clinical staffing specifically. The second one is the survey rating. So again, as I mentioned, about 18 months, every 18 months roughly, and that can go longer or shorter to some degree, but usually longer in this period of COVID. The government doesn't have as many resources to get out and do these surveys, but it's an unannounced survey. They show up at your front door, they walk in and say, we'd like to talk to you about how you're delivering care. And they will go through and spend the next several days to a week walking through, looking at the health records, looking at talking to people, talking to residents, talking to staff, making sure the staff are doing things the right way, observing care being delivered. And then they basically come back and give you a certain number of deficiencies, potentially. It is possible to have a deficiency-free survey. For larger organizations, that's a little more unusual. But they give you a rating, basically, and say, okay, you did lots of things well, and here are some of the things that you need to improve or you were not doing well. And that ultimately determines the survey portion of your star rating. Noting again, if you have anything that is too bad, I will say, and there are lots of different clinical criteria, that's sort of a generic term, they can actually, if they see something they think causes what's called immediate jeopardy to a resident or group of residents, they could actually shut you down that day and not let you reopen until, or basically provide required oversight until you remediate that issue. So survey is taken very, very seriously in skilled nursing. It's something that we did mock surveys on a regular basis, and most organizations do mock surveys, practice for the survey. They train their staff on what matters because it aligns well with clinical quality delivery. So it aligns well with doing what they should be doing anyway, but also how they communicate that can really make or break how the survey performance happens as well. And finally, quality measures. And those are the clinical quality measures, everything from falls to there's a whole list of them. I'd suggest going in to CMS's Nursing Home Compare and just dive into the star ratings. Do a little bit of research and understand the different makeup of the different areas of the star rating, specifically the quality measures, because that really talks about how the care is being delivered. And that's where quality improvement projects, and this is one area where there are a lot of new companies that are trying to find ways of helping SNFs improve their clinical quality, whether it's software or services or tech-enabled services or other things. How care is delivered and how care is measured and reported in skilled nursing will help you identify how you can help move that ball forward. So those three things, staffing, quality measures, and survey, are what make up the star rating. But again, understanding what an organization's star rating is very important from a reimbursement level as well, because You also, with hospital partners, they may have a mandate in your contract that says if you slip below 2 stars, we're not going to work with you anymore.
That's a great overview, and it touches upon another interesting relationship in this domain, which is that of SNFs with their third-party providers, such as outsourced PTs and OTs that visit their facilities and tend to bill directly to CMS. And so, can you maybe touch upon or describe how this typically works and how the money usually flows in those relationships?
Yeah, SNFs, skilled nursing facilities often work with a series of outsourced providers. It could be anything from PT and OT, as you said, to dining, to a number of different other areas. So rather than providing all of the services themselves, PT and OT are a great example because it's very hard to find a lot of great therapists. They're very hard to train and sustain. They're expensive. So a lot of PT and OT services for many SNFs are actually outsourced to third-party companies that do nothing but that for skilled nursing facilities. So we would work with an outsourced provider to provide those services on our site and in our facilities, but they would provide those services directly. And depending on the contractual relationship, either bill directly or work with us to do the billing there as well. Whereas, again, as I mentioned, dining or other outsourced providers, it could be an outsourced technology services provider, electronic medical records, it could be many other things. There are lots of different pieces that have to come together for a skilled nursing facility to work and to move forward with things. So it takes a village to run a skilled nursing facility, and it's a combined effort between a lot of different in-house providers and outsourced providers.
And that was definitely something I learned. If you have a clinical innovation or something to do with operations in those areas you mentioned, sometimes the customer is not actually the SNF itself, but these third-party providers that in some of these categories they have quite a lot of scale and sophistication and could be great partners, to actually sell into this otherwise fragmented domain.
Facility management too, even just running the operations of the physical facilities themselves, for example, that's sometimes outsourced, both with single SNFs as well as usually with sort of regional operators or larger providers. So running the day-to-day facilities themselves, that's again another possible place. And that, I mean, the interesting thing here, and just as an example, the way your facility works is so something that shows up in your survey. So let's say the refrigerators are not keeping the food at the right temperature. You can actually get a deficiency for that. So even down to that very specific, very sort of esoteric level, it's really important to understand the level of requirement and compliance that is necessary in skilled nursing. And then you look at who's providing that. Is that something done in-house? Is that something done by a third-party provider as well? So even though we had outsourced PT and OT, those folks essentially have to operate like we do and deliver the same level of or better quality of care, because as a skilled nursing operator, we're the ones being judged on that care delivery and measured, and then we are the ones with that star rating. So it reflects on us in a way that's very important. So they, again, as an operator, you pay attention to those relationships, and they're managed very closely, but they are in fact outsourced more and more commonly, so that the skilled nursing facility can focus just on delivering care.
Now, switching gears a bit, as we know, a strong value proposition is an important place to start, but it's not enough on its own. You need to also make it easy to purchase and implement your solution, and related to that, to plan for some of the barriers to adoption that SNFs face. And so in your experience, what do you wish vendors knew or were better prepared for before selling to SNFs as it pertains to organizational change, technology? You can kind of take it towards whatever domain is most top of mind, and we'll dig in further from there.
Everything from budget cycles and the strain on capital. So for example, SNFs they tend to be very capital intensive operations, everything from elevators to other things. Because of all the compliance, there's a lot of capital investment required to keep these places running. So understanding that that's a real strain on these organizations, and understanding how you're selling or positioning or structuring your solution, understanding that some flexibility from a financial model may be really important to align well with what that particular customer needs, whether it's, actually it would be better maybe that it's not capital, that we're going to find a way to push this into OpEx by building a subscription service rather than something that they just have to buy as a capital project, depending on their individual needs. So really understanding, again, their operating environment, their structure. Am I answering your question there, Jonathan? Because there are a few different things to consider, and that's just one of them. Budget and sort of a financial structure is really important to understand.
Yeah, that's an interesting place to start. We spoke about it verbally, the importance of being able to fit the purchase of your products both into capital and operating dollars. And it's something I've heard elsewhere, that some operators were complaining that it's one of the companies that I'm familiar with is a SaaS offering, and that they need to keep on paying for it every month rather than just owning it like a piece of equipment. At other times, I imagine that may be easier on the budget. So I am curious, what are the most common business models, within this domain for technology vendors? I've seen charging per building, charging, per resident. How is it in your experience usually structured?
That's a really good question, because this is one of the best ways to align with the business or with the organization and demonstrate to them that you understand how they operate and what their financial constraints are. One of the most effective ways I've seen billing done, and obviously not all suppliers and vendors can do this, but looking at, remember we talked about census and how many beds are filled? So there are some companies, some vendors that sell into SNFs that actually structure their offering to only charge based on the number of actual beds filled on an average monthly basis. So that the costs would actually fluctuate in alignment with what the skilled nursing facility is experiencing too. So let's say you had 100% occupancy, which would be fantastic and very unusual, then you would pay the maximum. But if you're only at, say, 70% occupancy, you only pay for those beds that are filled. That's a very effective way of demonstrating very clearly to the SNF operator that you are aligning your business with theirs. So again, I understand that that's obviously not possible in all sort of structures and approaches, but that is one way of again, aligning your business model with theirs.
Yeah. And so switching gears a bit, let's talk about tech savviness or sometimes lack thereof at times. And actually in the resources section of the SNF cheat sheet, we linked to the Ziegler 200 report, which is a listing of the top 200 largest senior living nonprofit providers or operators in the US. And one of the things that stand out there is that adoption of the EMR, electronic medical records, within this group is still just 72%. And I'd imagine it's much lower in some of the smaller groups. And so, part one of the question is, how do those facilities manage to operate in the 21st century without EMRs? And what does this imply for technology vendors looking to sell to SNFs? Is it even worthwhile approaching groups without an EMR? Are there other ways in which you can kind of integrate and affect clinical operations? Or is it just best to only target those that are already adopters of point-click care and Matrix and Net?
It's a really good question. And yes, the industry is still going through a transition, as I sort of started out talking about. A number of years ago, the government actually put up funds to help skilled nursing facilities pay for adopting EMRs and other technology tools. Unfortunately, by and large, that wasn't well used. And as you said, there are quite a few organizations that are still out there, we call it on paper. So they're still using paper medical records or very rudimentary, frankly, very rudimentary electronic medical record systems. Most of us as consumers of healthcare, sort of general acute care, we're used to people using the Epics and Cerners and other major EMR solutions of the world that are frankly quite a bit more sophisticated than many of the electronic medical record systems, with a few exceptions in long-term care. So even those with an electronic medical record system, you may find as a technology vendor, just as one example, that the APIs, the interfaces for software that you might expect from a general acute care hospital simply aren't there for a long-term care organization. So technology adoption has lagged significantly in skilled nursing facilities in general for many years. We're starting to see that change, but part of this, it happened for a few reasons. One, the regulatory environment is so severe that even to poke a hole in a wall sometimes takes a permit and 3 months and a couple of levels of approval. before you can actually move forward with a project like that. So there have been major impediments to progress. That was also, some of the regulations were there to protect people, because historically also skilled nursing facilities were places that had issues with care delivery, frankly, and where there were real problems. And the legislation that's out there and that has created this regulatory environment are a result of that. But it has also led to an environment where technology adoption has really lagged. So I think now we're finally entering an era where there is greater adoption by and large, and that's going to continue. We're seeing consolidation in the industry, and I suspect some of those organizations that are not able to work with hospital partners and have an electronic medical record system are not going to survive. We're going through a reckoning in the industry, and smaller operators are going out of business or being consolidated, purchased by larger operators. So I suspect those numbers are going to change probably more rapidly in the next coming 3 to 5 years as the consolidation happens. And I think there will be more technology adoption too, because there are actually requirements. There are now new regulatory requirements to provide data around the resident population. So without having that in an EMR, it would be overwhelming. So I think there are as I said, there are a couple of factors that are forcing the issue. COVID certainly was one that drove virtual care adoption, even in SNFs. So it's nice to see, that there was a silver lining, I guess, if you can see it that way, with COVID, in that it forced many organizations that had not adopted technology or even something as simple as Wi-Fi so that their residents could use a tablet and talk to their families. COVID changed that. So that process has started. It certainly is not up to the standard of either acute care or kind of general enterprise technology or other industry companies, but it is moving in the right direction. But be prepared for a much more rudimentary environment in many cases. And again, the infrastructure may not be there. The network and Wi-Fi infrastructure, the backend storage infrastructure, an understanding of an investment in IT, and that could be personnel as well. So you're starting to see CIOs in skilled nursing facilities. Not all skilled nursing facilities have a director of IT or a CIO. They may have outsourced it. They may have sort of just have a manager there that tries to keep all the technology together the best they can. But again, it's been an underinvested area historically, and that's starting to change.
And I think in the cheat sheet in section 2, there's a question there that mentions, IT details will often be more of a challenge than you think. And then you ask if vendors are going to actively seek to involve the customer's IT department or outsourced IT providers in the planning process. And
right.
And so I think it's an interesting insight that if you are working with a managed services provider, you may be dependent on a third party for very basic requirements of your solution, such as Wi-Fi. And you cannot underestimate the challenges of deploying in those settings.
They may have to sell in. That's talking about customers or sales prospects. You actually may have to sell into that MSP and explain to them why they should help adopt this solution for the model, in addition to the actual folks operating the skilled nursing facility itself. Sometimes a complex set of relationships that are keeping these organizations moving forward.
Yeah. And in the cheat sheet section 2, we also wrote a lot of questions around the nuances of integrating and deploying with EHRs that vendors should be aware of, and also some of the workarounds for overcoming some of the integration challenges for getting started a bit quicker, such as via the nurse call system. Would be great if you could kind of elaborate on how you've seen that done.
Absolutely. This is of critical importance because, as I mentioned before, you really have to understand how these organizations work, and finding ways of delivering value without trying to change their operational workflows. So working within what they're currently doing is the best possible way to be adopted most quickly. So if you take nothing away, work with the existing process, finding ways to improve the existing process and workflows, but changing as little as possible up front is the best way to go. So nurse call is a great example. So rather than having 3 different solutions that are reporting on the status of a patient or other things, nurses are very busy. They're running around trying to do a bunch of things, especially when they may be short-staffed. They're not going to pay attention to 3 different dashboards showing them different statuses. So that's why working with nurse call, that they're generally carrying around a phone or a mobile device so that people can call them for assistance from their rooms it's a great way to deliver a solution, frankly, because it's something that they're already doing. So if you can find ways of layering in new solutions or enhancements to existing operational or clinical workflows, that is by far the best way to approach selling into a SNF, because you're not changing very rigorous or very sort of well-established processes or protocols. You're doing something that already exists and you're just making it better. And nurse call is probably the best example of all of that too.
And so you're touching on another critical issue within part number 2 of the cheat sheet, which is planning for organizational change. And so what should vendors looking to potentially change clinical workflow or looking to be adopted by frontline staff know ahead of time to plan for the challenges of adoption among those frontline workers?
Part of the challenges they will face are the turnover of staff. So what you'll think you have trained everyone, you've got everything up and running, and then they'll lose 30% of the staff in the next 3 months. So you have to make sure that adoption doesn't just happen once, but you train the trainers and you set up sustainable functional and clinical processes so that it doesn't just happen once, it continues to maintain or sustain in the environment as well. So turnover is a really important consideration in ongoing training and support. Being much more aware and available to the clinical staff upfront and investing more in clinical resources. So first of all, from a credibility standpoint, if you are not bringing clinical resources to the table with you, you won't have any credibility. You need to make sure that it's clinicians talking to clinicians, generally speaking, and making sure that they are brought forth in a way that is present throughout the adoption process. So these are folks on the front lines that are trying to both adopt a new solution and trying to deliver the care and support to the residents or their patients on a daily basis. They're very, very short on time and they're stretched thin. So the more clinical support and assistance you can bring to bear, if you're getting involved in those clinical workflows, the better, so that you can make that load a little lighter for the nursing staff and show them that that you understand what they're doing and how to integrate with what they're already trying to deliver.
And so skipping around a little bit, one of the questions in section 3 is how do you scale up enterprise contracts from single site through multi-site to enterprise-wide? And so we talked a little bit about preparing for scale via train the trainer and integrating with workflow and so I wanted to kind of even dive a little bit deeper into in the SNF segment. What we often see is that vendors start with a modest contract, starting building by building, very kind of conservatively. And in your experience, what else can the best vendors do to speed up that lengthy process and actually get enterprise-wide adoption sooner?
The nice thing is when you're actually talking about a skilled nursing facility that's part of an enterprise, and generally speaking, you can make the assumption that they will have more infrastructure in place. There's more sophistication there in general because of just to operate at that sort of hierarchical level. So there's more in place there, but you will have to the best of your ability, demonstrate efficacy as quickly as possible on a single site before they'll let you talk to them about expanding beyond that. So make sure that you have to bring data. So make sure you're capturing data up front. I'd say even from the planning processes, explain what you want to capture, how you're going to capture those data, and make sure you're doing this very deliberately and transparently and say, look, we want to show you and demonstrate the efficacy of this solution and how it brings value in whatever aspect, again, whether it's clinical, technical, other things, making sure you understand what those key performance indicators or those data points are that you're going to use to illustrate the efficacy and the value of your solution, the money that you're saving, and how well that aligns with their model. So I think, again, once you're dealing with an enterprise that has multiple sites, you'll at least have the infrastructure, you'll have the technology, you'll have the ability to gather those data, generally speaking, more easily than with a single site. But it's even more important to make sure you're very specific and you're also aligned with what they care about. Don't just come up with random data points that they're not going to align with. Make sure that that's something you agree upon up front and you understand what their decision criteria are to progress to a multi-site or an enterprise-wide deal.
So zooming out beyond the cheat sheet, there's some trends that I think we're mutually excited about. And one of them is is the move from fee for service to value-based care, and that's happening here as well. And I'm curious, from where you currently sit and where we are today in the move towards that in SNFs, what are some of the biggest obstacles as well as opportunities associated with that? And you can tackle it from the perspective of technology, contracting, clinical capability, the financial perspective, but where do you see kind of the points of opportunity and the hindrances today?
There are a lot of opportunities with value-based care because what it does is it opens up more sort of diverse pathways to deliver value, rather than such specific fee for service. You're delivering this service at this price, and it's very specific. It opens up more opportunities to say, okay, there are other models we can pursue to deliver care in a cost efficient and effective, clinically effective manner that are more efficient and more effective than the traditional pathways. So it opens up an opportunity to redefine how care is delivered, the context, the location, the wraparound services, other things. And also it's forcing evolution in these organizations to prepare for this and to work with this. So part of all of that, the lack of evolution over the last number of years is changing and we're moving past that. So it provides some of the architectural rigor that has to be in there to bring new solutions in. People are more open to changing process than they have been historically. So in a number of different areas, and I'm being fairly general here on purpose, it really opens the door to a lot of opportunities in delivering new solutions, doing things differently than organizations have done in the past. At the same time, you really have to understand the difference. Again, you have to follow the money in terms of how these organizations are reimbursed and spend the time. Don't just go through buzzword bingo here. Dig deep into understanding how reimbursement really will work and how these solutions have to come together to deliver better care, more efficient care, because you will find clinical buy-in in many cases from the doctors and nurses and others that want to deliver the best value in their care that they're delivering as well. But making sure that you actually can, again, you have to be able to go back to the data and being able to prove that you're delivering effective, efficient care. There's going to be a higher bar for that as well.
Sure, and related to that, in the cheat sheet, we'll include a few links related to some of the means by which these organizations are moving to value-based contracting, and specifically SNFs. So getting into the acronym bingo, but that and ACOs. Yeah,
I'm very excited though. I mean, the fact that, and there are pros and cons with this. The fact that Medicare, there are now opportunities in Medicare Advantage plans. Medicare is being privatized in Medicare Advantage. And there are people very strongly on both sides of that fence seeing, okay, is care being denied in some cases, or are people, are these MA plans just out for their bottom line? Versus I'm seeing some really optimistic signs in certain MA plans that are delivering really incredible care in whole new models that integrate well. They provide better care coordination across the whole continuum of care. So it's an opportunity. Care has always been very fragmented. It's an opportunity to stitch the different pieces and parts together much more efficiently and effectively than we've ever seen in the past. So I am optimistic about that.
And related to that, and looking at the care continuum landscape, one of the big trends we're seeing is not only clear patient preferences towards more care in the community and at home, but this also aligns with, of course, payer interests for site of care optimization. And so in your perspective, what are SNFs doing to either counter this move or prepare themselves for it? What kind of investments are they making? And what are some of the critical skills gaps that vendors can help with?
SNFs, we're at an inflection point. Care is moving outside of the physical four walls. And that's not just skilled nursing, that's a general acute care. There's been an acute care waiver. Thanks to COVID, you could deliver acute care in the home as well. But the context in which care delivery is happening is absolutely shifting. And the smart skilled nursing facilities are looking at how they participate actively, not just in the care that's delivered in their four walls, but participating in the care continuum more, both sort of upstream and downstream. And that includes everything from potentially investing in home care or home health agencies to make sure that they can be participating in the care delivery after it leaves their specific facility four walls, to looking at how they take on risk, as we talked about briefly with some of these new reimbursement models, which can be a real challenge for them if they're not used to operating in those ways. But there's a way to do that that can be efficient and effective as well. So we're going to see some significant changes in how care is delivered, and absolutely is moving more into the home. And we're seeing a lot of innovation in those areas as well. Plus, the important thing is we're also seeing both Medicaid and Medicare push more reimbursement into and around home and community-based services and long-term care supportive services. So the care that's being delivered in the home and in the community. So we're seeing new investments in PACE and other models of delivering care in the community that are really exciting, and that also open up new opportunities and new ways of delivering care and services for some of the companies that may be interested in this video to participate in models that weren't or that aren't just the traditional SNF model. So you may have opportunities for partnering with new models of care that are delivering care not just in the four walls of a skilled nursing facility, but that are also following people home and making sure that chronic care management, for example, CCM is an acronym you may see out there that is delivering care in people's homes. It's checking in on people, making sure that their level of functioning is still staying stable and they're well served there. But there are new models of care that are opening up new opportunities for folks as well.
Thanks for that. And I think that's a great high note to wrap up on. And we covered a lot of ground today.
Yes.
The hope would be that this will be useful for either startups or investors or others that are interested in the segment to shorten the learning curve in assessing potential entry into this market. And I hope also that we were able to communicate not only the challenges of selling into this space, but also the opportunity and why we're both watching it very closely. And it would be great if you could give listeners your email or how best to reach you.
If you'd like to learn more, I'm on LinkedIn and really pay attention to the industry, and I'm actively engaged in a lot of conversations at multiple levels there. So I'd encourage you to reach out. There's a lot of learning we can do together on this. It's not a static environment. It's a very exciting time, and there are a lot of things that will be changing in the next coming years. So let's participate in the conversation and help evolve how care is being delivered. So reach out to me via LinkedIn. I look forward to the conversation.